Hello, my name is Jorge Zuniga, and I'm going to present to you a case study where we will examine the difficulties faced by radiology technologists on the field. In this case, the patient had a fracture and a multiple myeloma, which made positioning very challenging. This is evident when positioning a classmate at lab during positioning class. If you're going to do a lateral X-ray of the knee, for example, for the most part, they will position themselves. I will know that, or at most they will do what you request them to do. After all, it's a class that teaches us the positioning, how to position a patient correctly. However, in the field, you will find challenging situations where the patient is physically unable to follow the given instruction. For example, let's begin by going our patient's overview. The patient is a 60-year-old man who came into the emergency department after sustaining an injury on his right lower leg after falling. His initial chief complaint was severe pain over the proximal aspect of the right lower leg. The doctor ordered the following views from the imaging department. So he wanted a lower leg, a knee joint, femur, and a hip joint. The initial plan by the tech was to do a portable X-ray. However, we were unable to do because of the patient's inability to move the leg, and the room size was really small for examining. It was really small. So after examining the situation, it was decided that the best course of action was to move the patient from the X-ray room, from his room to the X-ray room. Once in the room, he was transported from the stretcher to the X-ray table. This is where the fun basically begins. So to start, I want to make sure I'm going to explain the procedures that we took for position, and then we're going to talk about what we see on the X-ray, because as you can clearly see, there is something going on these X-rays. And now we're going to also address the other evident pathology in the patients. So this positioning was challenging because the patient could not move. So to get the lateral view, for instance, to get the lateral view of the lower leg was easy. Basically his leg, his upper extremity, the femur and the knee joint were in an AP position, but the lower leg was basically on a lateral. So taking the lateral was an easy choice. We just pointed, center it, and we got the shot that you see here. I don't have the proximal shot that we got, but we can see the more challenging situation on this X-ray, which was the AP projection of the lower leg. So for this one, again, the patient couldn't rotate his leg to put on an AP. So what we decided to do was grab a couple sheets of blankets and make a good nice buffer of like 2 inches between the leg and the X-ray table. So I give space, and we put behind his leg the free cassette, and we basically did a cross-table AP projection of the lower leg, which was really cool. Again, I don't have the proximal image for when we did it on the knee to demonstrate the knee joint, and that's when we saw basically the fracture. Yeah, it was really bad. So that's what we did with the lower leg. And for the knee projection, so for the lateral knee, as you can see in this X-ray here, we basically flexed the patient's knee a little bit, make sure that he was in pain, so any movement was bad, but we just flexed it a little bit to get the lateral, and we put a pillow under his leg, under the knee joint, and then some blankets by the feet to provide support. And we also did a cross table basically, and all the cross tables we follow once we had the patient in that position, we follow to the cross table for the lateral distal part of the proximal part of the femur. So we show that cross table for that X-ray. The AP, as I said before, we already had the tube and the knee was already in position. We just basically showed that X-ray. Now the oblique was a little bit challenges as well, took a little bit thinking outside the box. So what we basically did, what I mentioned to the tech, was why instead of obliquing the leg, we just oblique the CR, which was basically give an angle to the CR to try to get the picture that we got. And this is what we actually got here for the knee. And then we went, to the other extremities, again, the femur. We had started placing this for the patient to provide more support and just kind of had the knee bended, but as you can see, it's not the perfect image, but it demonstrates the what probably the radiologist or the doctor wants to see. And we also did a proximal for the femur. I don't have the image. And then we have this, the hip. It was basically a lateral hip. We don't really did any special view for it because the way we had the leg, it kind of gave us that. So, it's not a perfect lateral, but also demonstrates the what we want to see. And so that's how the challenges that provide, doing an x-ray when a patient cannot really help with the positioning. Now, like I said, I want to address now the spots we observe on the bones, and that's basically myeloma. So as a pathology, it's a multiple myeloma or metastatic disease. And basically multiple myeloma is what it says here. It's a malignancy of plasma cells responsible for producing antibodies arising from the bone marrow. That's just a bunch of fancy words to say that it's a metastatic disease, which is a cancer that had spread to the bones. And the symptoms can be easily remembered by the word crab. You see here, Mr. Crab. So what they stand for is basically calcium elevation or hypercalcemia, renal insufficiency, anemia, and bone lesions. So those are the basic symptoms for the myeloma. Now, in order to address the fracture sustained and help the patient, the surgical procedure, the patient underwent a procedure called placement intramedullary rod and fixation screw, which is an intramedullary rod that is inserted and guided down through the fracture site into the bottom portion of the bone. Then they place surgical screws, on the top of the end of the long bone, and they goes through the rod that they inserted, and then goes to the other side in the head and secures it on the ends to stabilize the bone. So as you can see, they not only place the rod, or they don't only address the fractured bone, but they also decided to put it on the femur, as you can see on this x-ray. So they address the fractured bone, which would make sense as the broken bone, and bone is probably not gonna heal right. So this is gonna give it support and stabilize it. But they also did it on the femur, and you might wonder why. Basically, what we can deduce is that, as you can see on the distal part of the femur, so by the knee joint, the cancer had already begun to spread into the femur. So you have it here. This renders this bone brittle and fragile. So it's just a matter of time for it to break. So since the patient is already going through a surgery, instead of having a second surgery, they might as well just address that now and provide support and stabilize also that leg. Because again, the distal aspect of the femur has already some of the myeloma on it. And here's some more images of the post operation. And you can see here how they inserted the rod all the way basically to the ankle joint. And these are the screws that hold it together in place. This will be the lateral view of the ankle, and this will be the proximal view of the femur. So those are basically the challenge, some of the challenges and things that you will see, in the field compared to a classroom, and the cool things. And there is a fine line in between, being excited and enjoying something you're doing. Because when I saw these x-rays, I was amazed by it. I thought it was cool, but at the same time, you have that thought about, this is a patient that has cancer that is going through something difficult. The bone pain and you have when bone cancer, and he's going through all this, not only him, but his family. So there is a fine line between thinking that you saw something cool at the clinical and that you're amazed by something, and you know, the aspect of this is somebody's suffering. But I think it's just interesting that, you know, we can do these things and see these things. And hopefully what it was done for him, it will help. And that's it. Thank you for your time.